All right. Well, welcome. And thank you all so much for joining us today for ovarian cancer screening more than a pelvic exam, which is part of SWHR's Value of Diagnostics Within Women's Health series. I'm Katie Schubert. I'm president and CEO of the Society for Women's Health Research. And SWHR is the thought leader in promoting research on biological sex differences in disease and improving women's health through science, policy, and education. SWHR's Value of Diagnostics Within Women's Health series highlights the importance of advances in screening and diagnostic technologies and approaches across the lifespan with a focus on how we can improve health outcomes for women, with particularly related to female cancers, reproductive health, and bone health. And we are very pleased today to have two distinguished panelists joining us for today's public forum in recognition of September being Ovarian Cancer Awareness Month. Dr. Barbara Goff, Professor and Chair of Obstetrics and Gynecology at the University of Washington Medical Center, and Dr. Dineo Cabela, Professor and Chair of Obstetrics and Gynecology at Washington University School of Medicine in St. Louis. I'd also like to thank the sponsor of today's event, Roche. And as always, we are live tweeting during the event. We invite you to join us using the hashtag SWHR Talks Diagnostics, as well as SWHR Talks Cancer on social media. And with that, at this time, I would like to introduce SWHR's Science Programs Manager, Carolyn McPhee, who is moderating today's forum. Carolyn?
Thanks, Katie, and welcome everyone. Spanning from simple blood tests to X-rays to invasive procedures, modern diagnostic tests and procedures are an essential part of clinical care, aiding in the detection and monitoring of diseases and informing treatment decisions. Innovations in diagnostics can provide access to valuable information to help women make informed decisions about their health care across every stage of their lives. Ovarian cancer is a group of diseases that originate in the ovaries or in related areas such as the fallopian tubes. Ovarian cancer ranks 5th in cancer deaths among women, accounting for more deaths than any other cancer of the female reproductive system. Our presentations today will allow us to identify the tools available for ovarian cancer screening, highlight the value of early detection of ovarian cancer, and discuss the differential impacts of ovarian cancer on the health and well-being of women. I'll now introduce Dr. Barbara Goff to talk about the ovarian cancer screening guidelines and diagnostic tests. Thanks for joining us, Dr. Goff.
Great. Thank you so much for having me. It's really a pleasure to be here, particularly during GYN Cancer Awareness Month, which is September, and hopefully everyone is aware of that. So let me get my screen up and go here and okay, hopefully everyone can see. So as I said, we're going to talk about ovarian cancer screening and diagnosis. So we've already heard a little bit about what ovarian cancer is. And there are sort of three main types of ovarian cancer. The most common is epithelial, which arises from the outside of the ovary. This accounts for about 85 to 90% of ovarian cancers. And this is the cancer that sort of drives the poor prognosis of ovarian cancer. But there are two other main types of ovarian cancer, which are less common, that have a very favorable prognosis. One is germ cell malignancies, which arise from the actual eggs of the ovary. They account for about 5 to 10% of ovarian cancers. And then the stromal cancers arise from the hormonally active part of the ovary, and they account for about 3 to 5%. And as I said, these cancers typically occur in stage 1 and have a very favorable prognosis, even without chemotherapy. Again, we talked about the fact that ovarian cancer also includes cancers that arise from the fallopian tube and the abdominal lining, which is called the peritoneum. Some key statistics about ovarian cancer: there are about 20,000 cases diagnosed each year, about 13,000 deaths. Over 70% of ovarian cancers, and predominantly epithelial, present with stage 3 and 4. And as we've already heard, it is the most deadly GYN cancer. Now, there are a lot of things that increase and decrease the risk of ovarian cancer. Some of them are modifiable and some of them are not. So things that increase the risk of ovarian cancer are genetic mutations. And we've learned over the last 20 years or so that about 25% of ovarian cancers are due to hereditary causes, with the most common genes being BRCA1 and 2, but other genes like the Lynch syndrome genes, RAD51C and D, as well as a whole host of other more rare genes contribute to the risk of ovarian cancer. So knowing your family history is really important, and genetic testing, which we'll talk a little bit more about, is becoming much more commonplace. Endometriosis increases the risk of ovarian cancer, obesity, postmenopausal hormonal replacement. You probably all have seen a lot of press around talcum powder and huge class action lawsuits regarding against J&J. But really the data on talcum powder causing ovarian cancer is pretty conflicted and pretty weak. We used to think that infertility drugs were associated with ovarian cancer, but in fact, they're not. And there really is no association with a specific type of diet. Factors that decrease the risk: tubal ligation reduces your risk of ovarian cancer, oral contraceptives, particularly if they're taken for more than 5 years, breastfeeding, having children, hysterectomy reduces the risk, removal of the fallopian tubes reduces the risk, and then of course, removal of the tubes and ovaries reduces the risk to almost zero, although we don't eliminate the risk of peritoneal cancer when we remove the tubes and ovaries. Now, something in the last decade that has really come into our toolbox in terms of a prevention strategy for ovarian cancer is something called opportunistic salpingectomy. And this is when we remove the fallopian tubes, but leave the hormonally active ovaries so women don't go into menopause, which is a huge plus for women. And we know that up to about 70% of epithelial cancers actually start in the fallopian tube. And there's early population-based data from Canada, which have shown that opportunistic salpingectomy is very safe, and it has been efficacious in reducing the number of ovarian cancers compared to women who do not have their tubes removed. And typically when we do opportunistic salpingectomy is at the time of a hysterectomy or at the time of a tubal ligation, or maybe we're operating the pelvis to take out an ovarian cyst. And in women who are done with childbearing, this represents a true prevention strategy to prevent ovarian cancer. Now, unfortunately, we don't have very many tools in our toolbox when it comes to screening for ovarian cancer. And in fact, there have been 2 very large prospective randomized clinical trials looking at screening in ovarian cancer, one in the US and one in the UK, which randomized people to just regular pelvic exams and annual GYN exams, compared with adding an additional pelvic ultrasound and CA-125, which is a blood test and a marker that can detect ovarian cancer. And unfortunately, both of these studies showed that there was no reduction in ovarian cancer mortality when we initiated this type of screening. And in fact, in the US study, there actually was some harm noted because a lot of women underwent unnecessary surgery, which resulted in complications. As a result of this, the U.S. Preventative Service Task Force, which is kind of the leading body on preventative measures, has given ovarian cancer screening a grade D recommendation, which means there's fair evidence to recommend its exclusion at the time of a periodic health exam, because more women are harmed by screening than are actually helped in terms of early detection. The U.S. Preventative Service Task Force, though, does give genetic testing a grade B recommendation because there are so many opportunities for prevention when we identify an ovarian cancer risk gene. So right now, early diagnosis relies on symptom recognition, and educating women and practitioners about symptoms and promptly initiating follow-up is currently the best method of diagnosis. And while transvaginal ultrasound and CA-125 are not great screening tests, they are really good diagnostic tests in people who have symptoms or have an abnormal pelvic exam. So historically, ovarian cancer was considered a silent killer because symptoms weren't supposed to develop until advanced stages when chances of cure were poor. But in fact, work that our group has done has shown that about 95% of women with advanced stages, in fact, do have symptoms, and even 89% of women with early stage disease have symptoms. But the problem with the symptoms is they're pretty vague and often associated with other conditions. So the symptoms that are associated with ovarian cancer include abdominal pain, pelvic pain, bloating, increased abdominal size, feeling full quickly, difficulty eating, and urinary frequency or urgency. And you see that list. We've all had those symptoms from time to time, and most of us don't have ovarian cancer. And so through further work that our group has done, we've been able to develop an ovarian cancer symptom index, which includes asking women if they've been having abdominal or pelvic pain, increased abdominal size or bloating, difficulty eating, or feeling full quickly. And the symptoms need to have been present for less than a year. So the symptoms need to be new, and they need to occur frequently, more than 12 times per month, or at least 2 weeks out of 4. And what we found is that the symptom index, when we use this tool, is positive in about 90% of women with ovarian cancer. So it's a good way to think about who we should be doing more diagnostic testing on. So in conclusion, right now, unfortunately, there's no effective screening test for ovarian cancer. There's currently a lot of research looking at pap smears, blood tests, urine tests, but right now, early diagnosis relies on symptom recognition by patients and practitioners. Pelvic ultrasound and CA-125 should be the initial diagnostic test in women who have symptoms. And as I've said, it's important to know your family history because genetic testing really can offer opportunities for prevention. And for people who don't have genetic mutations, prevention strategies like opportunistic salpingectomy or oral contraceptives can really help reduce the risk of developing ovarian cancer. So that concludes my opening presentation. And thank you so much for letting me participate today.
Thank you so much, Dr. Goff. That was an excellent introduction to ovarian cancer screening and symptoms. Before Dineo gets started, I just want to make a reminder that for those who are tuned in live, you can submit questions at any time. So please feel free to submit them throughout the presentations, and we will try to address as many as we can during the panel discussion portion of the event. And with that, I will introduce Dr. Dineo Cabele, who will share more on addressing health inequities in ovarian cancer treatment and outcomes.
Thank you very much. I'm really honored, as well as Dr. Goff, to be here during Gynecologic Cancer Awareness Month to talk about ovarian cancer screening. My name is Dineo Cabele. I'm the chair of OBGYN at Washington University in St. Louis. And really thank you to the Society for Women's Health Research for inviting us. I'm going to focus on treatment. We know that advances in ovarian cancer have improved outcomes. Dr. Goff mentioned genetic testing, which will allow us to intervene for risk reduction. We really need better tools for diagnosis, which we don't quite have at this time, as she mentioned about the pelvic exam and the CA-125. And what I'm really going to focus on is treatment, survivorship, and care. And I want to talk about the fact that we're not, despite these advances, we're not really achieving what we would desire, which is equal care leading to equal outcomes for all women, including Black women who are disproportionately affected by poor outcomes after diagnosis with multiple cancers, including ovarian cancer. So there are significant and stark inequities in gynecologic and ovarian cancer outcomes for Black women compared to white women in the United States. And these are just statistics of 5-year survival for cervical cancer, uterine cancer, and ovarian cancer. And Black women are represented by the green bar here. The risk of ovarian cancer in general is about 1 in 78 women. It's more common among white women, but Black women have worse outcomes. And so a couple of reasons for this include sometimes delay in diagnosis. So this is an example of a patient who sought care for over 12 months with abdominal pain and increased abdominal girth with this huge abdominal mass. She was told she had fibroids, which is very common amongst women, but particularly common amongst Black women. And so her symptoms were essentially dismissed for a period of time until eventually she got the proper diagnostic imaging, which showed a large complex mass. And then she had a CA-125 that was drawn that was also elevated. She was eventually referred to a gynecologic oncologist and treated with the standard of care, which is staging surgery, removing the mass, doing biopsies. And she ended up having a stage 1A, grade 1 mucinous ovarian cancer. So in fact, this type of ovarian cancer has an excellent prognosis. It was diagnosed early, the mass was removed without rupture, and the patient did not require any additional treatment with chemotherapy and is alive with no evidence of disease. This is another patient who's a 32-year-old Black woman who really would have benefited from additional testing earlier on in her life. She'd been going to the doctor regularly with yearly visits to gynecologic and primary care physicians. And she'd been asked about her strong family history of breast and ovarian cancer, which was well documented, but unfortunately had not undergone counseling and testing until really delving more deeply into her family history, when it was finally recommended that because of her family history of multiple generations of ovarian breast cancer, and this arrow is at the patient, and a cousin with breast cancer and family members with ovarian cancer, she eventually was found to have a BRCA1 pathogenic mutation. And unfortunately, she underwent this risk-reducing hysterectomy and BSO. This should be at age 35, not 25. I apologize for the typo. But unfortunately, she could have had other interventions, such as oral contraceptives, which are known to reduce the risk for ovarian cancer earlier on if she had known this information earlier. So when we talk about confronting unequal treatment in healthcare, it's not unique to ovarian cancer. We know that disparity really talks about the ecology of healthcare systems, environmental factors, as well as discrimination and biases. And when we talk about some of the biases that we hold sometimes as physicians, I showed you the example that the pelvic mass in a Black woman is not a fibroid or a benign tumor, when in fact it's actually a cancer. So we need to counter this with awareness and education, just as we're doing today, or that BRCA mutations are not common among Black women. And again, raising awareness and education that these BRCA mutations or alterations can occur in any population. If you have a strong family history or a diagnosis of ovarian cancer, it's important to get genetic testing. And then there's some clinician and physician health stereotypes that Black women are not willing to undergo the aggressive treatment that's required to treat metastatic ovarian cancer or the proper staging procedure for early ovarian cancer. And we need to educate people about the reasons why it's so critical to undergo the proper treatment. Patient health stereotypes. So some of the patients that I've cared for throughout the years, this is work that, by the way, I'm quoting work from a task force where we talked about health disparities in gynecologic care. There's a stereotype in many parts of the country that if you perform a large operation, when air hits it, the cancer will spread. And so really countering this folklore with education about communities about the importance of surgery and surgical intervention in ovarian cancer survival. In fact, removing all visible tumor makes a huge difference in survival for ovarian cancer. The other myths that occur is that the diagnosis of cancer is automatically a death sentence, which is a stereotype and a myth. And in fact, some people don't even want to say the word cancer. What we know is that patients who are diagnosed with ovarian cancer, even with advanced stages of disease, are living years, more than 10 years with this diagnosis. And so it's not, it should not be considered an automatic death sentence. And then there are other issues around religious faith or strong beliefs. And we believe that working with church communities and religious communities to increase awareness will help counter the stereotype that any kind of medical intervention would make a difference. And then finally, the mistrust and not trusting doctors and not wanting to participate in clinical trials, not wanting to be perceived as a guinea pig or being experimented on. I think that this is where we can do more work as physicians and healthcare providers to become more trustworthy. And so in trusted therapeutic partnerships, when we're working with patients, families, and communities as physicians, clinicians, and healthcare systems, we have the expertise with our medical knowledge and lived experiences from what we see of diagnosing and treating these cancers. in partnership with patients who have the self-knowledge and lived experience of their symptoms, as Dr. Goff mentioned, that they're telling us about, and for us to listen and then intervene. We know that ovarian cancer is not silent. Dr. Goff's important work has shown that patients are telling us about their symptoms, but we need more funds for ovarian cancer care and ovarian cancer research so that we can identify better diagnostics and therapeutics. These are the symptoms that were mentioned, and we need to, as clinicians, look carefully, take detailed histories, make sure we understand the family history, order appropriate diagnostic tests and exams, and then actually offer the proper treatment, which is a combination of really specialized surgical intervention to remove all visible tumor if possible, followed by combination chemotherapy and maintenance therapy for many patients. And then, of course, finally, to learn about family history, the history of ovarian and breast cancer and other cancers that run in families, and perform cascade genetic testing to prevent people from developing these cancers in the first place. So I thank you for your time. I'm going to stop sharing my screen and again, appreciate the opportunity.
Thank you so much, Dr. Cabelli. Another fabulous presentation. So again, we are now going to enter our panelist discussion portion of this webinar. It looks like we have about 15-ish minutes to try to get through a few questions. So I will just remind all of our live attendees, you may use the Q&A function at the bottom of your screen. We may not get to every question, but we'll try to address as many as we can and address them common themes throughout. So to kick things off, I'll get us started. With any screening tool, it is possible to overscreen, overutilizing healthcare resources and creating undue patient burden. But there's also the chance that we're not catching patients before significant disease progression. So where is this optimal balance for cancer screening, particularly as we're thinking about women's health throughout the lifespan?
Well, I can start. I'm sure Dr. Cabelli will probably also intervene. And I think it really depends on the diagnostic test that you're doing. And I think one of the challenges with ovarian cancer is that while we have tests that can suggest ovarian cancer, to actually make the diagnosis of ovarian cancer, one needs to do either a laparoscopy or a laparotomy. And so having a false positive has very significant implications on women's health. Say if you take a mammogram, and you have a false positive, you end up with a needle biopsy, or if you have a false positive pap smear, you end up with a little cervical biopsy. And so the morbidity from the diagnostic testing is quite a bit less for those tests. And so that's why every test and every disease that we screen for is going to have a little bit different formula to make it work out correctly. But that is one of the biggest challenges with ovarian cancer screening, is that there is a fair amount of morbidity to actually making a diagnosis of that cancer. But for other diseases, it makes a lot of sense, because there's a very simple and inexpensive test that can be done to actually make the diagnosis.
Yeah, just to add on to that, one of the challenges that we probably didn't mention as much is that the most common type of ovarian cancer, epithelial serous, high-grade serous ovarian cancer, likely arises from the end of the fallopian tube. So trying to image the little finger-like ends of the fallopian tube is really challenging. And then, by the time the diagnosis is made, those cancer cells have already spread throughout the peritoneal cavity. So ideally looking for some sort of biomarker through a pap test, which doesn't exist right now, but many labs are working on that, or a blood test or a urine test would be ideal. The problem is that many of these biomarkers are testing the cancer itself, and we really need to identify that precursor and the precancer so that we can intervene before the cancer develops. And so there are a lot of challenges, lots of research is required. And the other final thing is the bar is really high for making this a test that you offer to the general population, because ovarian cancer is not that common of a cancer. And so you really want to be very careful offering a test that only affects a small portion of the population to everybody, because that increases your risk of false positives.
Great, thank you so much. And I'm seeing a lot of questions come in, so I'm going to try to combine a few just to help with the volume. There's a few questions about that prevention aspect. One asking, is it just the pill, or can Nexplanon implant and IUD help decrease ovarian cancer risk? And also questions about use of low dose naltrexone as a preventive measure. Any thoughts or further explanation that you can provide, and sort of what is best practice here?
Yeah, so definitely oral contraceptives have a long and strong effect on preventing ovarian cancer. Progesterone only, Nexplanon and IUD, less so than with the oral contraceptives. And so I think, you know, if you're really, if when we have people, as Dr. Cabelli said, if you have a young person who has a BRCA1 or BRCA2 mutation or is at very high risk for ovarian cancer, getting them started on oral contraceptives early is really an important thing to do. So that would be our first choice, just because there's so much evidence that's quite strong. It's also there's a dose effect response. The longer you're on oral contraceptives, the higher the risk reduction, and so that would really be the way to go in that situation.
Great, thank you. And I do see a question here asking for a little bit more around the cancer screening index that you mentioned, Dr. Goff. How widely is it used? And maybe just sharing a little bit more about how you're assessing symptoms.
Yeah, it's right now it's not widely adopted, I have to say, unfortunately, although there are a number of studies that we're doing trying to get it into the electronic medical health record, so that patients prior to a visit with their gynecologist or their primary care physician could be sent a list of questions regarding, you know, the symptom index. And it could include other things like, are you having, you know, bleeding in between your menses? Because that actually really helps. You know, if we talk about endometrial cancer, irregular bleeding is very common, and endometrial cancer is 3 times to 4 times more common than ovarian cancer. And so we're working really hard to sort of, you know, ask important questions prior to the visit, which would include the symptom index, so that practitioners have that information in front of them when the patient shows up for their visit. And so we're working at a number of different institutions to try to incorporate those questions and make it automatic. And my eventual hope is that once patients recognize this, then there would be artificial intelligence that would tell a physician, oh my gosh, this patient is having abnormal bleeding. You need to think about doing an ultrasound or an endometrial biopsy, or this patient is having these symptoms. You should think about ordering an ultrasound and a CA-125. So we want to take out any of the sort of, we almost want to take the physician out of the step and make this automatic, because most ovarian cancers are not diagnosed by gynecologists, but by primary care physicians who may not be as familiar with this information. And so that's really the focus of my research right now.
Great, thank you for clarifying. And so I think one of the things that, you know, we do sort of hear from people on our webinars is, you know, they see that maybe they have a risk factor. You shared a number of potential risk factors in your slides, Dr. Goff. What should someone do with that information if they have concerns about their risk? You know, for example, maybe they're taking hormone replacement therapy for menopause. Is there anything they need to do, or is this just, you know, helpful information tool to have in the toolbox?
Well, I think it's important to share, you know, again, depending, a lot of women, once they're done with childbirth, don't see their OBGYN again. And so sharing this with their provider, I think, is important. probably the most important thing is the genetic history. And so while, say if you have endometriosis, your risk is increased 2 times, right? Well, the risk of ovarian cancer is 1.5, 1.7%. So when we say the risk is increased 2 times, your risk might go up to 3.4%, something like that. So it still is incredibly, incredibly low. But I do think, again, informing your physicians about this, and particularly your family history, is really critical.
Yeah, I think
Great.
that the communication between the patient and provider, clinician, physician is really critical. And, being able to advocate for oneself is important. And that's why I think it's great to have forums like this for people to get the information, to be able to advocate for themselves in these settings.
And I just want to echo that. I think it's so important what Dr. Cabelli just said, because so many women who have symptoms are blown off. And so if you feel like there's something wrong with you, go get another opinion. I think that that's just really critical. We would never, put a new roof on our house without getting, several bids, but there's so many people who are like, well, my doctor told me it was just fibroids. So I didn't go and get another opinion because they're worried about insulting the doctor or, making the doctor angry. And everyone should feel very comfortable getting another opinion about their symptoms, and particularly once you have cancer, even more important to be getting more than one opinion about the treatment, risks and benefits. That is something that I think is way underutilized, particularly by women.
Great point. And I think kind of to piggyback off of that, something that we, are thinking about more and more is access to screening, particularly with COVID and the shift to telehealth. Rates of routine doctor's visits, have gone down. Women might not be getting their annual pelvic exam. What advice do you have to encourage this type of testing and make sure that, it's not falling to the wayside during these, continued unprecedented times?
Well, I think we're encouraging people to follow up on age-appropriate cancer screening. I think that, unfortunately, we don't have a one-stop shopping for all cancers. Cancer is one word, but actually is hundreds of different types of conditions. Even with ovarian cancer, there are common types like the high-grade serous ovarian cancer, but then there are less common types, small cell, germ cell, granulosa cell. And so the word cancer has multiple definitions. So there's age-appropriate screening for multiple types of common cancers like breast cancer, colon cancer, cervical cancer. And then there are some types of cancer like ovarian cancer where we don't have population screening, but we do rely on people telling us about their symptoms, getting normal exams, routine exams, so that we can identify any issues or problems. And that interaction is so important for people to regain trust in healthcare, and for healthcare providers to show that we're trustworthy, especially in these unprecedented times.
Great. And I think something that you brought up, Dr. Cabelli, in your presentation was about educating communities about advances in ovarian care and how important that communication is to countering patient health stereotypes. Do you have any other examples of partnerships or programs, resources that have been developed and have been effective in this space?
Well, I think that there are lots of groups that are really coming from communities that have traditionally been marginalized by, traditional healthcare. So, for instance, the Black Women's Health Initiative is really made some huge strides. I think that ACOG, our American College of Obstetricians and Gynecologists, is recognizing the importance of addressing healthcare disparities. There's a lot of work that I'm doing right now and a lot of colleagues in our field to show that if we can address some of these issues, critical issues for patients who are often marginalized, if we're good at that, that is going to improve care for everybody. Because that means that we really know how to communicate clearly in a way that reaches the margins, which means that we've reached far across, including the people who are closest to us, who really truly understand. And so I think that there are people who are aware of this. There's lots of work that's already being done. And after we're done, I'm happy to share some additional resources with you all.
Wonderful. It's so great to hear that we are having more and more resources in this space. And so I think we're getting a little bit slower on the questions. So I will go back a little bit to the kinds of screening. We have a couple questions just about maybe the innovations and looking forward into what might be available. We have some questions around if urinary biomarkers are something that are really available for early detection, and how reliable would you as clinicians see those as, and also questions about menstrual fluid as a new source for biomarkers.
Well, I'll start. There's a lot of research that's being done. I mean, there's no test that's currently, available, but we have, I think the idea of taking menstrual fluid or taking a little biopsy from inside the uterus to try to detect early cancer, because we do think that a lot of these cancers start in the fallopian tube. And so finding a signature in an endometrial biopsy, menstrual fluid, or pap smear really sort of seems to be kind of the way to go. I think probably more biologically plausible than say urine per se. There's also a lot of work looking at genetic signatures in blood and identifying, those. Everything is still, I would say, very much in the early stages. And again, then once we develop a test that's, sensitive and specific, then we have to look at cost, because that's a whole nother issue. Is what is the cost of these tests? And when you do a screening test, you need to be able to bring the cost down significantly so that you can offer it to everyone in the population, not just those who can afford it. And so again, that's a really important equity issue of making sure that there's an even playing field and that we're able to offer this to everyone.
Yeah, I agree.
Great. And we are coming quite close to the end of our time together. So before we wrap up, I'd like to ask one final question. We often have patients and healthcare providers, as well as researchers, policy professionals, tune into our webinars like this. What is one takeaway that each of you would recommend to viewers to help them support advances in screening for ovarian cancer?
Well, I would say we need more funding. So I would just say that in general, gynecologic cancers don't receive the same level of funding as, say, breast cancer or prostate cancer or colon cancer. They're often overlooked, and that has inhibited some of our advances. And so I think advocating for more funding for women's cancers is really a critical thing that everyone on this call can help us do.
I agree. I will add, listen to patients, listen to women. Ovarian cancer is not silent.
Very succinctly said, and so powerful. Thank you both for your time and your insight, and for giving us some really great, useful information today. And thank you to Roche for their support of this public forum and SWHR's Value of Diagnostics Within Women's Health series. SWHR will continue the conversation, #SWHR Talks Diagnostics, as we and others support the Jeanette Acosta Invest in Women's Health Act of 2021. This legislation proposes to increase access to preventive screenings for female cancers, such as ovarian, breast, cervical, uterine, vaginal, and vulvar cancers, particularly through the vehicle of safety net and reproductive healthcare providers. It also aims to reduce healthcare disparities and mortality rates among low-income women and women of color by decreasing healthcare spending and expanding health literacy and education about the benefits of preventative cancer screening for women. For more information, contact policy@swhr.org. And finally, we're also looking forward to highlighting one more area of women's health that benefits from innovations in screenings and diagnostics next month. Our next and final event in this webinar series will be on October 12th, and will focus on the value of diagnostic tools for screening and diagnosing breast cancer in recognition of Breast Cancer Awareness Month. We invite you to connect with us on social media and visit our website, www.swhr.org, to register for future events, download women's health resources, and sign up for our newsletter. We will send out an email with a recording of today's webinar to all registrants, as well as post the recording on the event's webpage for future viewing. So please be on the lookout for that and feel free to share with others. And of course, we will be continuing our conversation with hashtag SWHR Talks Diagnostics and hashtag SWHR Talks Cancer. Again, thank you all for joining us and being here with us today. And another huge thank you to our two wonderful presenters. And we hope you enjoy the rest of your day. Thank you.